The Queen's Jewish Link presents the Jewish Living Podcast, the show that examines the many facets of Orthodox Jewish life. Here's your host, Izzo Zwirin.
When most people think of genetic issues in the Jewish community, the immediate thought goes to Tay-Sachs disease and a number of other genetic conditions organizations like J-Screen and Dor Yesharim test for. These organizations are famous for testing prospective parents so as to minimize the spread of genetic diseases throughout the Jewish population. However, there are many genetic diseases that those organizations do not, as of now, test for. These are mostly conditions found in adults and, for now, are not part of the premarital genetic tests. However, that doesn't mean research isn't being conducted on them, and we were able to talk to someone who's all about disseminating information about genetic mutations.
Hi, I'm Temima Wildman-Lebowicz, and I'm a genetic counselor at Memorial Sloan Kettering Cancer Center.
Temima and I will discuss genetic cancers in the Jewish community and the BRCA mutations, as well as some of the things you can do to help facilitate early detection. Temima, thank you so much for joining me this week. So let's start off with a little bit of a background about genetic counseling. What is a genetic counselor?
So a genetic counselor is a healthcare professional who has special training in genetics, obviously, but also some psychosocial counseling training. And we basically integrate the medical and psychosocial implications of genetic conditions and genetic testing. And we also facilitate all those things coming together and educating patients about what it means to have a genetic syndrome and what management guidelines we recommend. We also provide resources to patients and support groups so that they can have continued support.
Oh, all right. So what does it take to become a genetic counselor? It's not one of those usual professions that we hear about. It's pretty specialized. So how does one become a genetic counselor?
Yeah, so it's a smaller field, but it's becoming bigger because there is just so much need for genetic counselors these days. As like the world is turning towards personalized medicine, there's just a lot more need for genetic counselors. So it's a small but growing quickly in this field. So I have a undergraduate degree in biology and a master's degree to currently 2-year programs to get specialized training for genetic counseling.
We've had on SD Rose from J-Screen, who deals with a lot of the premarital screening for Jews. What's the difference between what J-Screen does or what Dor Yesharim does and what a genetic counselor does?
Well, I mean, so those are organizations and they have at least J-Screen has SD and a few other genetic counselors that work for them. They're focused on testing people for the purposes of reproduction and to understand what the risks are for their children to have pretty severe lifelong illnesses. In the setting that I work in a cancer hospital, so I'm seeing patients and I'm seeing families who have either cancer themselves or a very strong family history of cancer. We'll get into that a little bit in more detail. And so we're really testing people for their own cancer risks and for their own management. It also helps us understand what the risks are for their family members so we can be on the side of prevention versus reacting to a cancer diagnosis and treating that. But we try to prevent it as well.
Okay, so this is the Jewish Living Podcast, so are you focused mainly on the Jewish population or are you focused more broadly on cancer in general?
So my specific position is in a general cancer hospital, so it's not specific for the Jewish community, but being in New York and at one of the top cancer hospitals, I tend to see a lot of Jewish people. And I think just being part of the community, I am a resource, so people who know me or people refer other people to me if they have questions or concerns that come up. So I see myself as a resource in the community as well.
Okay, so we're in a weird position in the country right now. So we've had a lot of dealing with COVID and some of the racial tension that's been going on. So I appreciate you coming on and talking a little bit about a lighter topic, cancer. So let's get into, because you deal a lot with the hereditariness of cancer. So let's talk about that first. Hereditary versus non-hereditary. Non-hereditary acquired, what I don't know what it would be if you are not getting a hereditary version, but what's the
Right.
difference between that? What are the markers that we're looking for to know if it's
So
hereditary or not hereditary?
yeah, so when we see patients and we're assessing to see if there's some sort of hereditary cause to their cancer, one thing we have to think about is that most cancers are actually not hereditary. But the reason why this is so important for the Jewish community is because, especially in the setting of breast cancer, which is a very common cancer in women, but there's a much higher rate of it being hereditary in the Jewish community, specifically in Ashkenazi Jewish individuals. So only about 10 to 15% overall of cancer is hereditary. The rest of it is, there could be some familial link, meaning it's something that's running in the family, but we don't have a specific genetic marker for it. But the vast majority of the time is just something that's kind of sporadic. We don't know exactly how to quantify environmental risk or other personal risk factors like smoking and obesity and things like that. So there's so many different causes and reasons why people get cancer, and it's hard to quantify things that are not specifically linked, but most of the time these things are kind of random.
Okay. Are there any diseases, cancers specifically, that are more prevalent in the Jewish community? And you could also talk about if there's a difference between the Ashkenazi and Sephardic communities as well.
So it's not my understanding is that it's not necessarily that the cancer rates are higher, but there's a higher rate of the cancers that develop being caused by a genetic mutation running in a family in people who are Ashkenazi Jewish.
And that same trend does not appear in the Sephardic community?
No.
Okay, interesting.
The Ashkenazi Jewish genome is a very specific set of genes and markers that we have, which is why, when you do things like what people are familiar with carrier screening before a couple gets engaged or has kids, things like Tay-Sachs, those are very specific to Ashkenazi Jewish individuals, although other people can have it too, but the rates are much higher in Ashkenazi Jewish people because it's a very specific set of genes that we have.
Okay. So in a previous presentation that you gave that I happened to see, you said that while cancer isn't necessarily more prevalent in the Jewish populations, genetic cancer is. Just didn't understand the explanation you gave as to why. Can you explain why genetic cancer is more prevalent in Jewish populations than it is in other populations?
So, there are different populations where this phenomenon happens, but like I mentioned, the Ashkenazi Jewish genes are a distinct ethnicity, and we have gone through a lot of different episodes in history that increase the rate of mutations in our population. So, for example, there's a population of, let's say 100 people, and then there's a pogrom or people migrate, they're running away from the pogroms and whatever it is, and you lose some of that population. So people are killed. So now from a population of 100, you're down to 50. And if one of those people had a mutation, so it was previously 1 in 100, now it's 1 in 50. So that's how the rate gets so much higher. And so with some of these genes that we know about, there's actually a rate of 1 in 40 in the Ashkenazi Jewish population for certain mutations that we call founder mutations, where one person had it and then they go repopulate. And so now that you have this founder mutation that becomes a lot more prevalent.
Okay, so just because the math kind of messes with my head a little bit, but wouldn't that also be true the other way? If you had 1 in 100 and then you lost 50, maybe that 1 would have been lost in the 100 as well. So we're talking about, obviously we're not only talking about 100 people and 1, it's a lot larger population in European Jewish history. So wouldn't that potentially have canceled out that mathematical issue? Additionally, if it's 100 people and there's 2 in the community, and you could lose 1, you could lose both, you could lose neither.
Right.
Statistically, just from a statistical perspective, I'm not sure if this is something that's up your alley.
I'm not a statistician, but meaning the way when they went back and they said, why do we see this mutation so prevalent? That was the explanation. So there could have been other mutations that were lost, but we wouldn't necessarily know about them because
Right.
some of these things are from like the Middle Ages.
Okay. All right. So you mentioned about these genetic mutations. I think that you mentioned that in your speech that I saw. Two of the common ones are BRCA1 and BRCA2. If you can talk to us about what those are.
So BRCA1 and BRCA2 are two different genes that work similarly. They are the most common causes of hereditary breast and ovarian cancer primarily, but if there's a mutation in these genes, that can also cause increased risks for pancreatic cancer in men and women, male breast cancer, and also for men to develop prostate cancer that tends to be more aggressive. And just to clarify something, when we are talking about these cancer risks, we're talking about mutations or changes within these genes. So all of our genes, we have 20,000 of them, have a specific spelling to them. And what we look for when we do genetic testing is any changes or like spelling mistakes in the genes. So there are 3 specific changes in the BRCA1 and BRCA2 genes that are called founder mutations in the Ashkenazi Jewish population. So this is what we're referring to.
You mentioned that it's breast and ovarian cancer. You did mention a little bit about prostate cancer and how men can get breast cancer in theory. It's rarer, but it can happen. It's important to note that even though these are breast and ovarian cancer, men still can be susceptible to this gene. If not for them, they can pass it down as well, correct?
Right, both of those things. So traditionally these genes, the syndrome that they called it was hereditary breast and ovarian cancer syndrome, which is it's a misnomer because like you just mentioned, there are risks for men, but the high risks are predominantly breast and ovarian cancer. But we see these other cancers at a higher rate in people with these mutations. And the male risks are particularly with BRCA2, but we can see them with BRCA1 as well.
Okay, is the difference between the two something very technical that I wouldn't understand, or is that something you could explain?
They're just two different genes, so the cancer
Okay.
risks are slightly different, but
Okay.
we treat them the same essentially.
All right, so we also mentioned earlier that there's a difference between how you operate versus how Dor Yesharim and J-Screen operate. Is this something that theoretically could be tested for before marriage? If so, do we do it? And if not, why not?
We don't test children for these types of genes because we don't think that kids are at risk to develop these types of cancers. There are certain ages where we see the risks go up, and that's in adulthood. For BRCA1 and BRCA2, we do start screening women around age 25 for breast cancer with specialized imaging. So that's pretty young, and not all women are married at that point.
Right.
Where I work, our mindset is kind of like there's no reason to be tested before age 25 unless someone wants to know, or if they're going to be using it for reproductive purposes to prevent passing it down, or if there's other risks involved, and we can talk
Right.
about
Well,
that.
I was going to say that the whole point of the J-Screen and Dor Yesharim is to prevent passing these things down. It sounds like something that if both sides have is an increased risk of a child having it. There's a whole reason that Dor Yesharim and J-Screen exist, to prevent these types of diseases to be, or in this case, a genetic mutation to be passed down. I'm not advocating to you as a genetic counselor that you should be the one on the forefront of getting this done. But I remember when we spoke with ST Rose that there are potentially other issues with over-screening for diseases that may or may not come to fruition. Is this one of those things?
So there's like a few parts to answer this question. So number one, the inheritance of it is different than most of the conditions that they're screening for in terms of reproductive carrier screening. So in most of the conditions that Dor Yesharim, well, probably all the ones that Dor Yesharim are testing for, and in most of them that J-Screen are testing for, they're all recessive conditions where an individual carries a mutation on one copy of their gene and the other copy of their gene is normal. And they're a carrier, but the vast majority of the time, they're not going to exhibit any symptoms or have any risks for their own health. So it's really purely for to understand more about the genetic health of their future children. When it comes to BRCA, the inheritance is different. It's a dominant condition, meaning you only have to have a mutation on one copy of your gene in order to have this increased risk to develop certain types of cancer. So first of all, the inheritance of it is different, which makes it kind of a little bit of a different conversation, because you're not just testing for purposes of your child, you're also testing for purposes of understanding your own risks, which is like a heavier burden, I would say, for people, especially younger people. And so one of the reasons why I said we don't necessarily test people before they are going to be doing anything about this for their own health is because, especially for people who are in their younger 20s, it can be very emotionally challenging to have this information, especially if you can't do anything about it. And like just kind of the timing of it is not great. There are definitely people who want to get tested for it before marriage, and that's fine. But I think in the Jewish community, that also brings up a lot of questions about shidduchim and what do you have to disclose and what do you not disclose. I mean, I would say in a lot of my from patients, that's a very strong concern, especially in people who are maybe more yeshivish or, going through the shidduch system. So I think that like there's different purposes of the type of testing, and especially in the setting of people who are kind of like, okay, we're going to get engaged, let's do the genetic testing to see if our kids would be at risk as the last thing on the checklist before we get engaged. Like testing for BRCA is not really the right setting for that.
Now, we're focusing a lot on BRCA1 and 2. There are obviously other genetic mutations out there. Some are more common than others. How easy is it to find out if you have one? How easy is it for research to exist to help deal with these mutations? And what do you do as a genetic counselor to make yourself knowledgeable on the new things that are coming out every day, every week?
So, we talk about BRCA a lot because that is the most common that applies to the Jewish community, I guess I would say. It is a pretty common thing that we see in the Jewish community. Again, it's 1 in 40. So that's like pretty high. It's 2.5% of Ashkenazi Jews, half of whom don't even know that they have a mutation. So that's the most common thing. And that's why we've been talking and focusing on that. There's another condition called Lynch syndrome, which is a colon and uterine cancer predisposition syndrome, among other cancers, but those are the most common. That's actually, we think it's one of the most common cancer genetic syndromes. So, when we see patients, and I'm evaluating, there's a lot of questions we ask about ages of onset and who in the family has been affected. Are there multiple generations affected with the same or related cancers? We look for rare cancers, and there's also sometimes some testing that's done on tumors that can help us understand more about whether there's any hereditary cause for it. So those are like the main things that we assess for, because colon cancer and breast cancer are also pretty common cancers that we see in population. In terms of more rare things, so, there are lots of different, again, like I mentioned, there's 20,000 different genes. Some of them are syndromes where we can see other types of health issues or skin findings or other physical things that also have cancer risks. Or, if we just see a lot of the same or related cancers in a family, sometimes that triggers patients to be referred to us for a genetic workup. So it really depends on what you're thinking about, what types of cancers. But most of the time when it's the same type of cancer in the family, not like, oh, my uncle had lung cancer, my other aunt had leukemia, and my mother had breast cancer. Like those are not necessarily things that go together. Which people may not know, but a genetic counselor would know. Right. Whereas if you have, 6 family members with the same exact, ALL, acute lymphoid leukemia, like then that's something that's more concerning.
Right.
And I am grateful that I work in a great place with a lot of ongoing research where we do testing. And we do research on a lot of these genes that are less known and more rare. And that's also how I learn about these things, because I work with the doctors who are publishing the papers. And so I'm very lucky that I just kind of get to absorb it and get notified when there are new publications coming out. And we do a lot of the research.
Okay, so let's talk about the preventative measures. Let's talk about primary prevention. So we're talking about screenings and tests like that. So if you could talk a little bit about the importance of those things and how early and often people should start doing that.
Again, it depends on what condition you're talking about. So if we're focusing on BRCA, and then there's also like two different routes. So one is early detection, which is what you use screening methodologies for. And then the other side of it is prevention, which is why you would do like preventative surgeries or sometimes take medication. So in the setting of BRCA, we generally start screening women from age 25 with breast MRIs. At age 30, we add in mammograms, and those are done every year. So once a woman is age 30, if she already knows she has a BRCA mutation or knows that there's one in her family and she hasn't been tested yet, then we would do like an MRI and 6 months later do a mammogram. So they have screening pretty often. Or women have the option of prevention, where they can have bilateral mastectomies and remove both breasts before there's any risk of or any known cancer diagnosis to prevent that from happening. It's a pretty drastic thing, and a lot of times when people kind of hear about BRCA and it's mentioned as an option, it's kind of like, yeah, I'll just have a mastectomy, whatever, and reconstruction. But like it is a much more complicated process than that, and it's not something to be taken lightly. And it's a personal decision whether somebody wants to do screening versus having a big surgery like that. And also, there's no specific timing that we recommend it because it is a personal choice. So there are people that I've seen that said, oh, my doctor said I have to have a surgery, I have to have a mastectomy. And even if someone has cancer, unless there's a cancer-related reason to do that, if it's just because of a genetic mutation, it's not obligatory, it's not mandatory. It's really a person's own decision how they want to manage that risk. In some cases, especially in women who've already gone through menopause, there can be options of also taking some medications to help reduce the risk of breast cancer from occurring. In terms of the ovaries, unfortunately, we don't have great screening. So traditionally, they used to do a blood test called CA-125 and an ultrasound of the ovaries. And they did that for many, many years until it was really proven that it was not effective in catching ovarian cancer at an early stage. And the symptoms of ovarian cancer, like bloating and feeling full, pain, things like that, are kind of broad and hard.
Right, that could be a lot of different things.
Yeah, and sometimes they're just things that women experience anyways as a normal life.
Right.
So it's very hard to pinpoint. So it's very, very hard to catch ovarian cancer at a early stage. And because of that, the recommendations are that women who have these mutations actually have their ovaries removed, typically around age 40 or when they're finished having children. So that's much younger than when a woman is going through menopause. And so that comes with its own risks and side effects as well. But that is very much a medical recommendation that we give people, women who have the BRCA1 or 2 gene mutations.
I would then say, what about men? Speaking as a man myself.
Exactly. Right where I was going.
Okay.
So for men, obviously they don't have a lot of breast tissue and they don't have ovaries. We mentioned that men can get breast cancer. So we tell men to do self-breast exams from age 35. Generally the breast cancer for men and the prostate cancer too, they don't happen at very young ages like we can sometimes see with BRCA1 and 2. So we don't start so much younger, but we tell men to definitely do self-breast exams, just feel the breast tissue and the armpit area for any lumps, bumps, bleeding, bruising, discharge from the nipple or the nipple inverting. And some men, if they have a lot of breast tissue, will have mammograms. But the guidelines are kind of like, consider a mammogram if you have a BRCA2 mutation in your man. They're not very specific. So I think it's kind of individual. It depends on whether they actually get any screening done. It depends, if there's a lot of breast tissue there for a man or not. You just can't physically do it for everybody. And then in terms of prostate cancer screening, which kind of in the general population is a little bit controversial, but in the men who have a genetic predisposition for it, we certainly recommend that they start a little bit earlier at age 40, and that's a blood test and a physical exam that's done by a physician. And we do that every year.
Are there any, just because of the title of our podcast, are there any increased measures for specifically for the Jewish population? Because it seems like all things that everybody should be doing throughout the course of their lives, like the annual screenings after 30 for women, 35 for men, all of those things. Is there anything that's specific to the Jewish population, not necessarily people who have tested positive for BRCA, anything else?
Well, I think in the Jewish community, in some parts of the Jewish community, women and men don't get the screenings that are recommended for the general population. So if a woman does not have a BRCA mutation and has no family history of breast or ovarian cancer, she still needs to be getting mammograms every year starting at age 40. Men and women, they all need to be getting colonoscopies every 5 to 10 years starting at age 50, regardless of their family history. And if they have family history, then more often than that, and maybe younger. So that's the only thing I would say is just the compliance with the population guidelines could be a specific issue in the Jewish community, which it might be in other communities too. But those recommendations I was going through are specific for people who have a mutation. Now, the other part of it is people who have a family history but don't have an identified mutation. They still may need some increased screening, and that's why it's important to speak to their physician or genetic counselor about what they should be doing. And then one other thing I think to point out is just that people don't necessarily know that they're at risk for a BRCA mutation. And so we kind of talked about how it is pretty common. And so there's been some studies, and I think they're doing similar studies in Israel. I forget exactly where it stands now, where they're actually talking about testing all Ashkenazi Jews, regardless if there's a family history of cancer or not. So I mentioned that like 50% of people who carry BRCA mutations are not aware of it. So either they don't have family history, or they don't realize that their family history is significant for it, or, you know, all their great aunts and uncles were killed in the Holocaust, so they just don't know that there could have been a family history of cancer.
Right.
So, you know, the guidelines have actually changed to say that anyone of Ashkenazi Jewish ancestry could consider getting tested for BRCA. Whether your insurance will cover it or not at this point, not very clear, but that will probably be changing over the next 5 to 10 years.
So I wanted to touch on one thing that you said and then bring up one other area. The first thing that I wanted to touch on is that you mentioned that there's a family, it could be a familial history, but they haven't been diagnosed with any specific genetic mutation. My thought immediately was, just because they haven't been diagnosed with one yet doesn't mean that it doesn't exist. It just means possibly that we haven't discovered what that mutation is yet. Since we're coming out with a lot of research constantly, it's possible that there is this mutation, just we don't know what it is. Is that accurate? Am I making that up?
I think so. There's two different things there. So number one, what I was saying is that, you know, there's been a lot of studies. So specifically, there was a study in Israel about 6 years ago or so, where they tested men. I think some men, had family members with breast cancer, and some did not, I believe. And they found that equal amounts of the men essentially had these mutations. So that basically shows that, you know, even if you don't have a family history, you still have that 1 in 40 or 2.5% risk, if you're Ashkenazi Jewish, to carry one of these BRCA mutations. So you may not know that you have it because you may not have family history, but you still have it and you still have the cancer risks. So that was number one, what I was trying to say. What you're saying is that, you know, for some families, there's a very strong family history of cancer, of specific cancers that look like they're being caused by something in one of the genes, and we just haven't discovered it yet, right? So, you know, 20 years ago, we were only testing people with strong family histories of breast and ovarian cancer for BRCA. But now we do these we do panels. Basically, we test many genes at one time. So where I work, we test for like 7 to 8 genes generally for breast and ovarian cancer. Other places, they do these really, really big panels, like 80 different genes. So there's a lot of differences in what different people, different hospitals or healthcare providers test for. But there's a lot more that we know now in terms of cancer risks and what genes can be causing it than we did 20 years ago. So research is always changing. And if there's a very strong family history, that's why we still give recommendations for people to perhaps have more screening or start at a younger age, because they may still have this familial risk, or there could be some genetic risk that we just have not identified.
So the one thing that I wanted to bring up is that if somebody gets a test for a BRCA, generally two options, positive, negative. Positive, we know what that means. Negative, we already spoke about. That doesn't necessarily mean you can't get other cancers, and it doesn't mean you can't get the same cancers that don't necessarily relate
Correct.
exactly to the mutation. But I did see that you mentioned in your presentation an unknown test result. So if you could talk a little bit about what that means,
Yeah.
how does an unknown test result even happen?
So it's not that it's an unknown test result. The type of what we call those variants of unknown significance. So it's not
Okay.
that the result is unknown, it's that we don't know what the result means. So just to take a step back, so when we're talking about the Ashkenazi Jewish mutations in BRCA1 and 2, most often patients will be tested for those first if they're Ashkenazi Jewish, and that's really a yes or no, either positive or negative. We see it or we don't. But when we do something called sequencing of the genes, where we look at the sentence of the gene letter by letter, look for any changes, we can get either positive, we find a known change that is harmful, or negative, we don't see anything, or whatever we do see we know is benign because there's been enough studies done. And this third type of result that we call a VUS, or a variant of uncertain significance, means that we find a change, or a variation, or an alteration in the gene, so some sort of spelling change that is different than our typical spelling, but we don't know whether it's actually disease causing or if it's benign. Now, those things are just basically a lack of scientific data. We haven't studied enough people with this particular change. There's not enough literature on it. We just don't have enough data to make a call about its interpretation or its classification. And so what we tell patients with those types of results is basically to keep in contact with us, because these things do change as more people are tested and more research is done. Those variants can be updated to be either harmful or benign. 90% of the time, they ends up being benign. So we don't give recommendations based on them. We tell people to, basically continue as per their family history, whatever their family history is. We give recommendations, but we would never tell someone to have a surgery based on this type of uncertain result.
Okay, let's move on to secondary treatment options. So primary is a prevention. Secondary, they've already been diagnosed with the cancer. What are the management plans? I mean, obviously it's going to be different based on individual things, but what are we talking about on a broader spectrum of understanding of what are the different types of measures that we take?
So, when someone's diagnosed with a cancer, it depends on what cancer it is, type of cancer. Usually patients will be treated just based on the cancer itself. So how large the tumor is, where it's located, so therefore what type of surgical options they have. If it's spread to the lymph node, do they need to have chemo first before they have a surgery or after? So most of those decisions are based just on the cancer itself. But sometimes, and especially in the settings of metastatic cancer, where it's already kind of spread through the body, there are specific drugs that can be used in the setting of a person with a genetic mutation, either in their tumor or something that they were born with. Tumors often have mutations in them, but sometimes there aren't necessarily things that we're born with. So a woman can have a BRCA mutation in her breast cancer that's not actually something that she's born with, or she can have a BRCA mutation in her whole body, which would include the tumor as well. And so there are a specific class of drugs that can be used to treat that. And also in the case of ovarian cancer and pancreatic cancer, with this other syndrome called Lynch syndrome, we often will use immunotherapy for patients with metastatic cancers related to Lynch syndrome. They tend to work really well. So, it does allow for us to do targeted therapy. And it's not just isolated to those two syndromes. There are other genes also that sometimes it's an option. And there's a lot of ongoing research there too.
All right. So speaking of ongoing research, I know that obviously there's always more studies going on in terms of genetics, but if you could talk about the B4 study, first of all, what is it? And if there's any chance of joining such a study or another study that might be coming down the pike.
Yeah, so the B4 study is, it stands for BRCA Founder Outreach Study. So basically it is a multi-center study. The main sites that are doing it, 4 cities were involved. So New York City through Memorial Sloan Kettering, Boston through Dana-Farber, and I don't remember the other hospital, in LA and in Philadelphia. So we basically had a study that was going on for about 2 years, I think. We had enrollment open where we tested people who had at least one Ashkenazi Jewish grandparent for these 3 common BRCA mutations. And it was free. So people could just sign up and get tested. It happened to be that a lot of people who did it had mutations in their families. And I think there was a higher number of men. So it's just men who never bothered to get tested, or for some reason they never got tested, but they knew about a mutation in their family. So it was a really interesting study. And there was a lot of different aspects to it, but one of the main goals was how to get people to enroll. So there was a lot of efforts to do community, to reach out to people through the community. So not through their medical providers, but through their rabbis or community leaders. Didn't really take off. They weren't really so interested. Which was just kind of like interesting to see and to hear, and to, they had like Facebook ads, and they had other types of email blasts that they would send out, and it didn't really get people. But then when they had the Federation send out an email, that actually a lot of people signed up through that. So it was very interesting in a lot of different ways. We closed the study to accrual in March of this year. And we are currently fundraising and planning for the next phase of the study. So the first phase was we called the pilot program. Basically, it was only open in four cities in the surrounding areas, and we wanted 4,000 people to be enrolled. So we met those goals. And now we're planning for the next part of it, which we're still kind of figuring out what that will be. But making it easier, so not having people need to do blood, but we'll do saliva, and figuring out if it's just going to be for the Ashkenazi Jewish mutations, or if there's going to be options for more expanded testing for people who need it. So it's kind of still in development. Not sure when it will reopen, but you can always go to the website b4study.com. Hold on, let me check it.
B4 is BFOR, just so people who are looking for it.
So on the website, there's somewhere where you can sign up for updates to find out when it's reopening for the next phase. So there's a place to do that, I believe, when it will reopen. Yeah, so it's BFOR study.com. I'm not the main genetic counselor on it. I have a wonderful colleague who is really great and has been like running the show for it, but I do have some participation.
Okay, so I'm looking at this list of hospitals that are involved with this. So you mentioned them. It's University of Pennsylvania. It's Penn. It's Beth Israel in Boston. It's
and Dana-Farber. There's 2 different doctors. Yeah.
Right. It's Sloan in New York, and it's Cal in Los Angeles. Are those the primary cancer hospitals in the country? Are there other ones that are out there I'm just asking for listeners that might be elsewhere in the country, because you have a lot of representation here on the coasts: Philadelphia, Boston, Los Angeles, New York. Anywhere in the middle of the country? I'm assuming the Mayo Clinic is probably a good place that has
I
that
mean,
type
there's a lot of different places that have genetics. I think these are like some of the top cancer genetic doctors. So the different institutions that are listed are based off the physician who's one of our primary investigators. There's another page on the website you can look at to see who it is. But those are so I would say that our physicians are probably some of the top cancer geneticists out there. But there are certainly a lot of other good places for cancer treatment. I mean, MD Anderson in Texas is a cancer hospital as well. Mayo Clinic, I'm sure. They also have like we work with another one of their geneticists on a different project. And I think also for the purposes of the study, it was focused on places where there was a big Jewish community. So because it was focusing on people who are Ashkenazi Jewish.
So in that regard, is there a place in Israel that is partnered with this, or is that a
We're
leading...
working. That might be something in the works, possibly. I don't know where it stands, to be honest. But there are some people there that are working on similar things. Dr. Efrat Levi Lahad is one of those physicians I know works closely with Dr. Offit, who's the head of our genetics department. I mean, there's a whole bunch of places in Israel where they do this type of thing. Shari Tzedek has a huge department for it, I think. But in general, I'll say that if someone is not in one of these areas or at one of these institutions, then they're looking for a genetic counselor or they need some input on whether the cancer in their family is hereditary. They can go to the National Genetic Counselors website, nsgc.org. And there's a place where you can search for a genetic counselor in your area, and you can click off what kind of specialties, whether it's cancer or preconception or prenatal. You can choose what you're looking for and find the genetic counselors in your area.
Great. And we'll provide links to all of these sites at the show notes and on all of our social media pages. Is there any place that on social media that your program is findable, or that do they run a Twitter account, an Instagram account, type of a thing?
I mean, we have like a genetics page on the Memorial Sloan Kettering website that we've recently updated. And then the Before Study website is a great resource. We do have an Instagram account that I run. It's not so active since our accrual is closed right now, but you can look at it, as well as Facebook and Twitter. I believe we have a Twitter page as well.
All right, we'll try to link to those on each individual platform. I have more of a personal question, because we started on the personal side. I never get to ask this question because the people that I have interviewed in the past, they're not in as much of a heavy field as this is. Does having to deal with this type of a thing weigh on you outside of your job? Do these things do you feel these things having an effect on you, that you're dealing with the cancer patients and the genetic counseling part of it so much? Does it, as I personally feel like a big weight on my shoulders right now just talking about it for the last hour. I can't imagine what it would be like for somebody who does this on a day in, day out basis.
So it's funny, I do get that question from time to time. Most of the time we're actually giving people good news that their test results are negative. And so that is a good feeling. There are definitely some stories and some patients that I think back to just because their situation or their story was kind of sad or difficult. But I would say the vast majority of the time it's actually because people, again, only 10 to 15% of cancer is caused by these mutations. So most of the time we're giving good news that people are testing negative, which people I think find a lot of relief. And then, other times, even if we're giving bad, quote unquote, bad news that someone tested positive, we're giving them an opportunity to feel empowered and make decisions based off of that, or for their family members to make decisions where they can really be changing the course of their life and then we have some role in saving them, essentially.
Wow. All right. That was a more positive outlook on this than I was anticipating. I'm glad that it is that way. Is there anything else you'd like to share with us before I let you go?
I think there's a lot more to say in this topic that we didn't get to cover in an hour.
Well, yeah.
But, so I think just for people to know that there are resources out there. I mean, I'm happy to answer questions if people have, but there are resources. This is something that we don't talk about so much in our community, although I think more and more it is something that comes up. But I think often also takes the back burner. People just kind of want to bury their head in the sand. So I think just taking time for people, if they kind of relate to this and think, oh, maybe I need to go get tested, taking the time to think about it. Also knowing that meeting with a genetic counselor is not a commitment for testing. We are here to talk to people about why they shouldn't get tested and whether it's really the right decision or what the right timing is for them. So it's not, a lot of people were like, oh, why should I get tested? Or I don't want to know, but it's not that simple. Come find out the information, see what applies to you, and then make an educated decision about if and when you should get testing done.
So you opened the door to people reaching out to you. Where can people reach out to you?
I guess they can email me. Although I won't be available.
Do you want to drop your email on the podcast, or do you want to have people reach out to me directly and then I can put them in touch with you?
I mean, how many people do you think will actually reach out?
10,000 people. No, I have no idea. It's up to you.
Either way. I guess I can contact you.
All right. If you need to contact Temima, you can reach out to me and I will provide you with her contact information. All right. Temima Wildman-Lebowicz, thank you so much for joining us this week. And this was really eye-opening, some of these things that I really had no clue about. So thank you.
Thank you. Thanks so much for having me.
My thanks to Temima Wildman-Lebowicz for coming on to discuss hereditary cancers this week. If you are interested in learning more about genetic diseases and the testing that goes into it, check out episode 12, The Next Generation of Genetic Testing with St. Rose of JScreen, or episode 21, Raising a Child with Genetic and Chronic Conditions. I think you'll find both episodes have their own unique take on these areas of medicine. Or, if you want to wait until our next episode drops to hear the dulcet sounds of my voice, that's okay as well. Until next time, as always, Kol Tov.
The Jewish Living Podcast is produced by Swirly Pikus. Our theme song is The Band by A.B. Rottenberg from Journeys 4. You can email the show at jewishlivingpodcast@gmail.com. You can also find us on Twitter at Jewish_living. The Jewish Living Podcast is recorded in conjunction with the Queen's Jewish Link.